So now I'd like to introduce our first speaker, Dr. Carlos Santos. Carlos Santos is a transplant infectious disease physician and population health scientist at Rush University Medical Center. So please give a round of applause for Dr. Santos.
Hi, everyone. I'm Carlos. I'm an infectious disease physician, and I specialize in the care of transplant patients. So several years ago, I was an intern at Rush, and I was inspired to go into transplant medicine by my mentors. I was always interested in infectious disease. We get to be medical detectives, and when things don't go right, they do tend to call ID. But then I rotated with my mentor, who was a transplant infectious disease physician. And I watched this patient just walk out of the hospital after a transplant. And for a physician, that's always very inspiring. Initially, I thought my path to medicine was in cancer. But then after I saw how well transplant patients did, I was inspired to go into transplant infectious disease. And so that's my field. And the method by which I study my field is with outcomes research with informatics infrastructure. And so what that is data is stored in our electronic health record, and there's means to get the data, pull the data, analyze it, and then turn it into information. And so that's very important. Is a lot of data is just warehoused, and it needs to be turned into information that then is turned into knowledge that can help patients. So that's what I do, is I take these large data sets, analyze them, and try to apply them to patient care. It's a pleasure to be here. And so this is the title of my talk, which is Safer Living with COVID-19. I do think that it's time to live with this virus. We've been in crisis mode, locked down for 2 years. And at this point, science has really stepped up, and we know how to control this pandemic. So I think that it's time to start living with this virus. And so these are my disclosures. I receive royalties from UpToDate and some consulting fees from Merck. And also, I'm a natural optimist, which is a difficult thing to be. Which is a difficult thing to be in time of pandemic, because we also tend to be wrong some of the time. But I find that it's important to survive as a natural optimist. And so today we'll be talking about the prevention of COVID-19, again, living with this virus. And I'll be talking about vaccines, and I'll be talking about treatments for COVID-19. Science has really stepped up, and we now have monoclonal antibodies against COVID-19 that are safe and effective, and an antiviral pill that would fight COVID-19. And so as far as origins and virology, so COVID-19 is the disease, but the virus that causes it is called severe acute respiratory syndrome, coronavirus 2, or SARS-CoV-2. And so the first SARS happened more than 10 years ago. It started in China and then spread to Hong Kong and then Singapore. But for the most part, it was confined to Asia. And I remember this because I was an intern at the time. I'm Filipino, so I was coming from the Philippines, coming to Chicago, and I was traveling during that time. Now, the first SARS did not spread beyond Asia because it was predominantly spread within hospitals. So these are two different viruses. So the first SARS it was most infectious as patients got worse and worse and worse. And so they had more and more virus when they progressed to pneumonia. For SARS-CoV-2, it's the opposite. They were most infectious when they were asymptomatic. Let's think about that for a moment. And so patients with SARS-CoV-2 are most infectious around 2 to 3 days before they get symptoms. And that's really why it's been so hard to control this pandemic. Is it because patients didn't know that they were spreading the virus, they had no symptoms, and they can spread it. Compare that to SARS-CoV-1, where they're most infectious when they have a lot of symptoms. And so by that time, they were landing in hospitals, and it was confined to hospitals. So compare that, so SARS-CoV-1 was a nosocomial or a healthcare-associated infection. It spread within hospitals. SARS-CoV-2 is a community-acquired virus, and it spread in our community. And so respiratory transmission is dominant, and droplet transmission and close proximity is more important than aerosol transmission, which is spread over distance and time. So this is supported by contact tracing studies where proximity within 6 feet is the most important. And the R0, which is the number of people that are infected with the virus, is 2 to 2.5, which suggests predominant droplet transmission. And so on average, one infected person would infect between 2 to 3 people, and that's on average. That's the R0. Aerosol transmission is less common and is associated with enclosed spaces with poor ventilation and with groups performing expiratory exertion, like singing. Less important are direct contact and fomites, and there's no evidence of transmission by fecal, oral, sexual, or blood-borne routes. So again, transmission is predominantly droplet within 6 feet, and aerosol transmission is less important. And this is a study of how we found out that transmission occurs before the presence of symptoms. And so day 0 is when they first get symptoms. And you could see that even up to 7 days before the first onset of symptoms, there's already viable virus that was found in these patients. So again, they were very infectious even before they got symptoms. And this is the epidemiology of COVID-19. And we all lived through this. And so initially in March of 2020, there was this peak here, but this really was just the tip of the iceberg. The truth is COVID had been circulating even since probably November of 2019 in the US, and it didn't come to the forefront until March of 2020. Hospitalization rates were very high at that time, which shows that this was really just the tip of the iceberg. We had increasing numbers of COVID, and then the big peak happened over the winter of 2020 into January of 2021. And so that was right before the vaccines rolled out. And so we had this big peak here. It came down, and then we had our third peak right here. And this was driven by the Delta wave. And so the Delta variant is much more infectious than the original variant. And so the R0 for the Delta variant is closer to 8 compared to the original strain where it was 2. And so it's a much more infectious variant than the original SARS-CoV-2 strain. And so looking at this epidemiology curve, we really see the phases through which we went through the pandemic. The initial phase, I thought, was marked by fear. So there was a lot of fear. We didn't know what we were fighting. So if you reflect as to what we were doing in March or April of 2020, it wasn't clear just how deadly the virus was. It wasn't clear how it was spread. We didn't know how to treat it. There was no vaccine. There were no medicines. There was a lot that we didn't know. We were running out of protective. So we were running out of PPE or equipment that would protect us from the virus. And so it was quite, I think, a fearful time. But we got over that fear very quickly. And then it was just sorrow. And so by the time the second wave was coming through, at least within the healthcare field, it was just a lot of sorrow because patients were dying and outcomes were not good. But I think now moving forward, again, we have vaccines and we have treatments. And so it's a time for hope. And so again, when I reflect about this pandemic, it really has gone from fear to sorrow to hope. And again, this is going back to the epidemiology, where now it's mostly Delta. It's the Delta strain, which is predominating in this current wave of infection. All right, let's stop there because that's the initial part of the talk, which is transmission and epidemiology. So again, it's a respiratory virus. It spreads even before you're symptomatic. There have been 3 or 4 major waves. This latest wave is driven by the Delta variant. It's much more infectious with an R0 of 8. And let's stop there to see if there's any questions. And I don't know if anyone's monitoring the chat. Yes. And so the question is about monoclonal antibodies. And so there are 3 monoclonal antibodies that are available now. There's Casi with Imdi, and then there's BAM-E, and then there's Satro. These are abbreviated terms. It's just kind of what I call them. And they're all excellent. And so they decrease hospitalization or death by 70%. So that's a lot, 70% decrease in hospitalization or death. They're monoclonal antibodies, so they really power up your immune system. And they're tailor-made against COVID. And so the best outcomes always are to give it within 7 to 10 days of being symptomatic with COVID. More than 10 days out, it may not be as effective because the initial phase is driven by the virus. The latter phase is driven by inflammation, the immune system overreacting to the virus. So it's important to hit the virus when it's trying to replicate. So if you get COVID, if you get symptoms consistent with COVID, get tested right away, because the antibody requires that you be positive with COVID microbiologically. It's not just suspected COVID. And it's important to get the monoclonal antibody within 10 days of developing symptoms. So that's a great question. You know, this is again one of the hopeful things. Between March and June of 2020, we suddenly had to ramp up our clinical trials. It was very important to figure out how to treat the infection. Clinical trials generally, at least in infectious disease, are driven by HIV and fungal infections in general. These are slow infections and they're not all that common. So imagine ramping up your clinical trial infrastructure to respond to a pandemic. So that's what we had to do at Rush, at Northwestern, and through university settings. All of a sudden, it was all hands on deck, enrolling patients, getting the trials through. And there has been success. And one such example of success are the monoclonal antibodies. Again, finding that if you give it early, within 10 days of symptom onset, that it decreases hospitalization or death by 70%. So imagine all these medicines we give. We give medicines to fight the flu. Tamiflu, for example, would decrease severity of the flu by 40 to 50%. So a 70% improvement in outcomes is outstanding. Yes.
Which COVID shot is the best shot?
Which COVID shot is the best shot? Excellent question. I like being an honest person. So one of the joys of my work is I get to just look at the data and then speak the truth with a poker face. That's nice, right? I'm not a politician. I'm sorry to politicians in the room. You guys are important too. But as a data scientist, I really think the best shot is Moderna. That's what you got, yeah. Initially, early in the pandemic, when Pfizer came out and Moderna came out, and then Janssen came out, right? And so Pfizer reported a vaccine efficacy of 90%. Moderna reported a vaccine efficacy of 95%. And Janssen reported a vaccine efficacy of 68%. And so those are just numbers. And it was obvious even from the first that Moderna was better. And then politics came in, and these drug companies need to make money. I know I'm being recorded. That's too bad. And Janssen is an inferior vaccine. It just is. The numbers do not lie. 68% vaccine efficacy versus 90 to 95%. But then the powers that be thought that if patients try to hold out for the best vaccine, that they may not get vaccinated at all. So they made this judgment call saying that it doesn't matter which vaccine you take, just take a vaccine, which is fine. In times of emergency, I thought that was very wise. Now that there's no vaccine shortage and people have a choice, we could again look at the numbers and see that Moderna is the better vaccine. Number one. Number two, that's the reason for when they looked at the booster trials. Now they're looking at boosters. So you know what they're recommending for boosters? For Pfizer, it's the full dose. For Janssen, it's the full dose. And for Janssen, it's within 2 months of getting vaccinated. For Pfizer, it's 6 months from vaccination. For Moderna, it's just a half dose of the vaccine as a booster. And that's enough. Again, because it has always been the better vaccine. Yes.
Well, thanks for that information. So I'm 6 years old with a transplant kidney. I've had 3 doses of the Pfizer vaccine. And I have tested my antibody levels after the second and the third dose, 1 month after. And I have 0 antibody levels. And now I just know from last week that the CDC has approved a booster for people like us, immunosuppressed population, but that's 6 months after the third dose.
Correct.
So that's about between 4 and 5 months away for me. Based on what I just heard, it sounds like, and that now that we all have the option to mix and match doses of, mix and match the vaccine, that I would go and get the Moderna vaccine as my booster. I'm not looking for advice, but then based on what you said and what I have read, it almost seems reasonable to get the Moderna vaccine, because after 2 times of testing, I have no antibody levels and I'm still here.
Okay, well, that's very interesting. So let's break down that question. First is a Pfizer vaccine, when it was tested against immunocompetent hosts, the vaccine efficacy was 90%. So that's good, right? Generally, immunizations are about 50% effective. And so these vaccines are already excellent at 90%. Now, some patients will not react as well to the vaccine because of immunocompromise or age or comorbidities. And so it's possible that in the real world, that it would be lower, the vaccine efficacy would be lower for certain kinds of people. Now, one of the ways that people try to figure that out is by measuring antibody responses to the vaccine. And there have been 3 or 4 studies in immunocompromised hosts showing that maybe between 30 to 40% of patients who got the Pfizer or Moderna vaccines had antibodies, and the 60% did not. Okay, and so antibodies are just one arm of vaccine response. There's 2 responses. One is the antibody response, which is what's measurable. And the other one is the T cell response. So think of antibodies as ways to gobble up the virus, okay? And think of the T cell response as cells that kill the virus. So those are 2 different arms. And so when these investigators, when they measure antibodies, they're measuring only one part of the response. They're not measuring the T cell response. So that's one. Number 2, at UC San Diego, they looked at transplant patients, and they looked at Pfizer and Moderna vaccines, and they found that the vaccine efficacy was 80%. And so compare that to the antibody responses, where only 40% had an antibody response. But then when you look at actual outcomes, the vaccine efficacy was 80%, which again shows that you're only measuring one arm of the vaccine response. It is lower, but it's not as low as the antibody studies would suggest. Okay, so that's one part. So that's cause for hope, right? Because 80% vaccine efficacy for immunocompromised hosts is still pretty good. And then if you couple that with mask wearing and social distancing, I think it's still fine, number 1. Number 2, for boosters, in general, and this is in general, it's better to get the same vaccine. If you got Pfizer or Moderna, it's still better to get the same vaccine. And I'll tell you why. The booster is specific to the kind of cell that it's trying to boost. So the sequence needs to be exact for the booster to work at its best. Okay, so when I talk to kind of cell biologists about this, the sequence is important. If you're boosting something, it needs to be the same one as before. And so if you got the Pfizer vaccine, I still think that getting the Pfizer booster is the best course of action. If you got the Moderna vaccine, I think that getting the half dose of Moderna is the best option. If you got the Janssen vaccine, start over with the Moderna vaccine. Okay? Remember that the Janssen vaccine was single dose, and it was an adenovirus vector. And there are side effects with the adenovirus vector. And so the vaccine efficacy is lower. The platform they used was different. So it's important to consider all those things. And so what I've been telling my patients is that if they started out with the Janssen vaccine, to just go ahead and go for a Moderna with 2 shots. Yes. I think there was a question. You're good? Okay. Yes.
Dr. Santos, I know you said that you are a natural optimist, and that's absolutely
Yes.
fantastic. Speaking of that optimism, do you envision that for people like myself who got Pfizer, do you see this as an ongoing every other 6-month booster situation, very similar to people who get the pneumonia vaccine? It's a 2-pronged event. Do you see Pfizer continuing to be every 6 months going forward in order to ensure its efficacy?
So I think that depends on how much COVID is still ongoing in the country and the city, I think. And so we would only, I think, deploy these vaccines when there's significant activity. And so if you're at the point where you got 2 doses of Pfizer or Moderna, and then you got a booster dose, and you're still practicing social distancing, mask wearing, I think you're fine, especially since now the Delta wave is starting to abate. And so Delta, it peaks in 2 months and then goes down. That's exactly what we're seeing. It started in other countries. It would always peak in 2 months and then come down for reasons that we don't completely understand, actually. And so it will depend on the activity of COVID in the community, number one. Number two, at this point, about 70% of people are fully vaccinated against COVID. Kids now can also get vaccinated, so hopefully that will go up. By some estimates, 1 out of 2 Americans have gotten COVID. 1 out of 2. And so there's also some natural immunity. It's not as good as vaccine immunity, but it's something. And so I'm hoping that at this point that we wouldn't see as big a wave as we've seen in the past, on the condition that a variant that is not controllable by the vaccine does not emerge. And that's the unclear part, is a variant can emerge from anywhere in the world that would escape both vaccine immunity and natural immunity. So that's the question. Now, if that variant emerges, then these drug companies need to react and make a vaccine that's specific to that variant. And that's the challenge, which is why now we see with this slide, the epidemiology, which is why now people surveil for these variants. They sequence these variants. So we have a bank of genomic data knowing when variants are emerging. So again, we do have the tools to surveil and find these variants. Okay, yes.
So what you're saying basically is if you had the Moderna, then you should get the Moderna booster.
That's
And if
correct.
you had the Pfizer, get the Pfizer booster.
That's correct.
What if you've gone, like they said with the Moderna, after 6 months, you're supposed to take the booster. It's been longer than 6 months for me.
Right.
So what does that say for me? Should I go back and take the Moderna and now that it's been approved?
Right.
And then
So,
and then my next question is, because it was so everywhere you looked, you could get it. Now I don't see where I am to go to get those boosters.
Right. I mean, the boosters are now everywhere. Any commercial pharmacy, you could get the booster. If you got your second dose of Moderna vaccine more than 6 months ago, you could go ahead and get the booster shot. And the reason that you don't need it within 6 months is because they don't think the immunity wanes within 6 months. So you have some time. But if it's been more than 6 months, go ahead and get the booster.
Okay.
Hi. Thank you. I was told there is no booster for Moderna.
There is no.
There's not. There is one or there's not.
What was the question? I didn't catch it.
I was told that there is not a booster for Moderna. Is there a booster?
There is a booster. It's a half dose.
Okay.
Yes. And so boosters are recommended for all 3 currently available COVID vaccines. And it's for anyone greater than 65 years of age, anyone with comorbidities, hypertension, diabetes, asthma, kidney transplant, cancer. There's a whole list of comorbidities. Anyone in a congregate living facility, like a nursing home. Anyone who's a frontline worker, like a fireman, a policeman, a teacher, a physician, a nurse. So those are the groups where boosters are recommended for.
I have a question, please. Follow up to the gentleman about the antibodies. I'm 7 years post heart and kidney, and my transplant center does not do the antibody testing. Any recommendations on where or how we can be tested to make sure that the vaccines are working?
So that's a good question. So the question is about, should I get my antibodies tested? And so a gentleman here also got tested for antibodies. And so the best test for checking if you responded to the COVID vaccine is a T-cell test, which measures the T-cell arm of the vaccine response, and a neutralizing antibody test to check for that other arm, the antibody arm, okay? The commercially available antibody tests do not check for neutralizing antibody. Those are just done in these basic science labs, and it's very expensive and very involved, and so are the T-cell tests. Now, companies came out with these antibody tests, but they do not test for neutralizing antibody, and they do not test for a T-cell response. And so when you get the number, you don't really know what it means. You get a number. And sometimes it says that it's undetectable, but again, you don't know what it means. And so in my practice, I don't check for antibodies because the gold standard is not available commercially. So I'm a pragmatic guy. I would just tell people, get the booster if you're eligible and maintain social distancing and mask wearing. Because the test is not perfect and may be misleading. Yes.
Piggybacking on what he said, wouldn't it be like crucial to kind of try to get that T cell and the other cell testing done to see what our population, to see how it's actually working when it's so expensive and we can't attain it? So wouldn't there be some kind of clinical trial going on or something where we could actually test it and like kind of put people at ease that, yeah, you have that immunity and just continue with your social distancing, but you're safe, because a lot of people aren't feeling that kind of security.
Yeah, I think that it's a challenge. So the tests are expensive and you would need to scale it up to a certain point to reassure people that they're adequately protected. The current efforts are really geared towards just getting vaccines into people, to convince vaccine hesitant people that these are safe, and to develop these treatments So this additional test for reassurance, it would be excellent if they were widely available and validated. But as far as I'm aware, there isn't a clinical trial looking at the feasibility of checking for vaccine responses in a standard way. Because that's really what needs to be done, is it needs to be in a standard way. They need to be valid tests, as opposed to these potentially misleading tests that just lead to a lot of anxiety. Yes.
Excuse me, let us bring you the mic before you ask your question. I'll answer one and then I'll ask one and then Mateo will bring you the mic. Dr. Santos, how do
Yes.
you advise your patients who are immune compromised about air travel?
About their
Air travel.
their
planes,
travel.
Traveling on planes.
Yeah, so this is an important question. It's about safer living too. Travel does pose some risks. The safest thing, of course, is to be a hermit and just stay in your room and just never go out. But we are going to try to live with this virus. Now, as far as travel, I think that airplane travel, there's a risk there. It's a closed space. People may not wear masks. And if you're masked, it's still not 100%. And if you're immunocompromised, the vaccine, although it works reasonably well, may not work as well for you compared to an immunocompetent person. So I think that's a challenge. So what I tell patients is that if you need to travel, I would suggest wearing an N95 mask, which is the highest caliber of mask and screens out most of the virus. So it's a 95% efficacy. I tell them to wear shades. I don't tell anyone to wear these shields. You just look weird. And honestly, I don't think that they're any better than these large shades. And I tell them that, you went through a kidney transplant or chemotherapy or whatever it is that you had to do. And the goal is to live. Right? And so at some point, you just have to live. You've been through so much. And so if you really need to travel, take these precautions. Make sure that you're boosted. Make sure that you're wearing an N95 mask, some eye protection. Be mindful of, if you get symptoms, to seek the testing right away so you could get these treatments right away. So again, time to try to live with the virus. So planes are a risk, trains are a risk, any kind of congregate travel, there's a risk. Yes.
I'm looking at here a test that I took for the antibody. It's the SARS-CoV-2, that AB, I guess, antibodies, IgG and spike. And it says here that the test is intended to help identify individuals with antibodies to SARS-CoV-2. And in parentheses, COVID-19. The results of this semi-quantitative test should be interpreted as an indication or degree of immunity or protection from infection. But like you said, the only number that I had here was the, I guess, the less than 1. So basically, this test really doesn't tell you really anything, does it?
Yeah. I mean, it's a challenge. When they made those antibody tests, they were meant to try to diagnose COVID. So you make these antibody tests to try to find traces of the COVID. They were not made to assess vaccine efficacy. So that's, I think, a challenge. And there's 2 kinds of antibody tests. One is the spike, which is what's in the vaccine. And the other one is nucleocapsid, which is not in the vaccine, but in the virus. So it even gets more complicated looking at these antibody tests. Is it spike or is it nucleocapsid? Yes.
I wanted to ask about, because now is the flu season, or it has started. I know I got my flu shot. I get everybody here who was in dialysis has. But then there's the flu shot, then there's the pneumonia shot, then there's the for seniors, the chicken pox.
Yes.
So how is that interreacting with these the booster and these shots?
Yeah, so that's a good question. So the first thing is the flu will start at some point. It will start soon. And the flu shot is important. The second is that if you're not yet boosted against COVID, if you're immunocompromised, it's good to get boosted since there's additional protection. And third is that the shingles is a very painful thing to go through. You know, I almost think that shingles should also be a never event. And I've seen shingles affect the face and patients are just in severe pain. It's pretty awful. And so I think that these vaccines are here to help all of us. Now, the good news is that the immune system has enough cells to send to shingles, to send to COVID, and to send to the flu. And so if you're vaccinated, there's more than enough naive cells to get trained against the vaccine. So they don't interact. That's good. There's more than enough cells to protect against all these different infections. The second thing is that they tell us that you could get it all on the same day, that you could get the flu shot and the COVID shot and the Shingrix shot all at the same day. What I tell my patients is to space it by 2 weeks. So at this point, I tell them, if you haven't, so start with the flu shot because most of my patients are already COVID vaccinated. So start with the flu shot, then get the Shingrix shot, and then get the COVID booster and separate that by 2 weeks. And the reason for that is that there's side effects. People feel tired and they're having fever. And so I do think that it's better to space it out. The guidance will say that you could take it all at the same time. But then I've seen some people and even colleagues of mine who did the flu shot and the COVID booster at the same time. And it seemed like the side effects were a little worse. Not severe side effects, but they just had the fever and feeling very tired. But yeah, I mean, this is another important thing is that the Shingrix shot, the shingles shot, is about 70% effective. It's a 70% vaccine efficacy. So that's pretty good. And it's important to not get the shingles. If you're over 50, strongly consider getting the Shingrix shot.
Is that recommended for transplant recipients as well?
Yes, it is. So the amazing thing with the Shingrix shot is that it's not a live vaccine. And so there's vaccines. There used to be the Zostavax. That's the old one. And that was live. So the Zostavax we cannot use for transplant recipients because the virus is viable. And so for the Shingrix, it's not a live vaccine. It's only components of the virus, but it's not the actual virus. Okay, any other questions about vaccines and boosters and antibodies? It's a lot. Yeah, it's a lot.
I'm sorry, is
It's
this booster
twice.
only once or we have expected it next half a year again, the second one?
So the Shingrix shot, it's 2 shots, 2 months apart.
Booster, I'm talking about booster.
Oh, the COVID, it's only once. Yes, it's only once. Yeah. Yes, we have a question over there first.
Yes. Does Medicare cover the antibody shot?
Yes, the antibody treatment is covered by insurance. Yes. Yes, and there was a question here.
Okay, I'm coming.
Dr. Santos, when you were speaking just previously about efficacy of like Shingrix, you mentioned 70%, which is real good. Is that just for the general public or is that for transplant patients?
That's for the general public.
General public. Okay.
Yeah, I think the challenge with these vaccines when they're being tried out is for clinical trials, it tends to always be the healthiest people who would volunteer for a clinical trial. So when you see the results of a clinical trial, expect it to be the best possible scenario because they tend to be the healthiest, they tend to be, they wear the masks, and so it's the best possible scenario. Anything in the real world will be a little lower than that. And unfortunately for immunocompromised, it will be lower. Just how low, it's unclear, but starting from 70%, even if it goes down to 60% or 50%, that's still a 50% reduction in harm. So it's not small. Okay, any other questions? So we discussed a lot. I think just to summarize, we said, I think vaccines are good. Pfizer, clinical trials, 90% vaccine efficacy, which by the way was a miracle. And so when the results first came out, we were just hoping for a 50% vaccine efficacy. And so imagine the pandemic starting in March of 2020, and then by November of 2020, there were already preliminary results showing a vaccine that was 90% effective. That's a miracle, right? That's a gift. And so that was very important. And then the Moderna, it came out, it was 95%. So I think that's just a marker for success. So again, clinical trials, Pfizer is 90%, Moderna is 95%, Janssen is closer to 68% vaccine efficacy. Boosters are recommended for anyone over 65. In general, it's recommended that you get the same vaccine as before. For Pfizer, it's full dose. For Moderna, it's half dose. For Janssen, it's full dose. Although again, I would urge you to consider a messenger RNA vaccine if you got the Janssen vaccine. And so that's the second thing. Third is antibodies. There are these commercially available antibody tests, but we're not quite sure what it means. And there's two arms to a vaccine response. One is the T-cell response, the other one is the antibodies. And these commercially available antibody tests test for antibodies, but they're not the broadly neutralizing antibodies that we need to measure vaccine efficacy. Okay, so those I would say are the three learning points. Okay, I'm just going to check the time real quick, okay? Okay, it's 10:03. Wow, that flew fast. And there's a whole talk still. Yes, okay. But this is more important. I think getting the questions, I think we actually covered a lot in the talk. So I'll just move on to showing the vaccine trials. So this is the Pfizer mRNA vaccine. We had talked about this. And this is Pfizer showing 90% vaccine efficacy. And so the blue line is people that were randomized to not receive the vaccine. The red line is people that got the vaccine. And you see it spread right there. And that's a beautiful looking Kaplan-Meier curve. And that's 90% vaccine efficacy. This is the Moderna trial. So again, the same thing. That line on top are people randomized to not get the vaccine, and that line in the bottom are people that got the vaccine. So 95% vaccine efficacy, which again is a gift. And this is the Janssen vaccine. And so you can see that the lines separate, but they don't separate as much as Pfizer or Moderna. You could see it right there where the line on top are people that did not get the vaccine, and the red line, some of these patients still got COVID despite getting the vaccine. So this is the Janssen trial. As far as booster shots, again, we had discussed this. So it's recommended for people who are 65 years and older, age 18 and greater, who live in long-term care settings like nursing homes, age 18 and greater, who have underlying medical conditions, and age 18 or greater, who work or live in high-risk settings. Okay, then I'll skip this one. So let's move on, I think, briefly to these monoclonal antibodies. So this is Casirivimab with Imdevimab. This is the Regeneron product, and it's approved for treatment of mild to moderate COVID-19 in adults and pediatric patients 12 years of age and older, weighing at least 40 kilograms. They need to have a positive result of direct SARS-CoV-2 viral testing, and these are patients who are at high risk of progression to severe COVID-19. And so there's been a 70% decreased risk of hospitalization or death. So that's excellent. And again, these are some Kaplan-Meier curves showing that the lines separate depending on whether they got Casi with MD or not. And it really shows that there's a 70% decreased risk of hospitalization or death with these monoclonal antibodies. This is another monoclonal antibody called BAM-E, so bamlanivimab with etesevimab, and its treatment of mild to moderate COVID-19 in adults and pediatric patients with positive results of direct SARS-CoV-2 viral testing who are at high risk for progression to severe COVID-19. And so this is my advice for outpatient management of COVID. So consider Casi with MD or BAM with E in patients with mild to moderate COVID-19 who are at high risk of progressing to severe COVID-19 or hospitalization. Patients should take their temperature and measure their oxygen saturation twice a day. If their oxygen saturation drops below 94%, advise them to seek care immediately. Patients should self-quarantine. For immunocompetent patients, that's 10 days from the onset of symptoms, or 1 day without fever in the absence of antipyretics, whichever is longer. For immunocompromised patients, that's 20 days from the onset of symptoms, or 1 day without fever in the absence of antipyretics, whichever is longer. Household contacts are at greatest risk of contracting COVID. Advise contacts to separate in the home as much as possible, and advise patients and contacts to wear masks at all times in the home. And I'd like to close with this new antiviral. It's called MOL. So molnupiravir is an oral antiviral treatment for COVID-19. It's a ribonucleoside analog that inhibits the replication of SARS-CoV-2. In an interim analysis of a phase 3 trial, 7.3% of patients who received MOL were hospitalized through day 29. Compare that to 14% of placebo-treated patients who were hospitalized through day 29. So that's a 50% reduction in hospitalization or death. So not as good as the monoclonal antibodies, but it's 50%. It's fine. And so the FDA is convening an advisory committee to discuss emergency use authorization. This is not available yet, but should be soon. Okay, and I think I'll stop there. If there are any questions, I'm also mindful of the time. I could feel Monica getting a little antsy. Yes. Oh, that's anti-fever medicine. Anti-fever medicine. So Tylenol, things that bring down fever, and antipyretic. For everyone, don't use things like Motrin or ibuprofen. Those are bad for the kidneys. I don't know if your doctors tell you, but stay away from these NSAIDs or non-steroidal anti-inflammatory drugs like ibuprofen. They really hit the kidneys hard. So I stay away from those. So Tylenol is good, paracetamol, acetaminophen. Okay, it's been a pleasure. Thank you everyone for your attention.